Interventions with a King. Discussion and commentary based on articles from Jack, Cardiovascular Interventions.
I'm Spencer King. I'm editor of Jack, Cardiovascular Interventions, and I'm here today with Dr. Valerian Fernandez, who is at the Medical University of South Carolina. He's director of the cath lab at the VA there and has published a very interesting paper with his colleagues on the subject of hypertrophic cardiomyopathy and how we manage it with alcohol septal ablation. Welcome.
Thank you very much.
Now, this technique, of course, is somewhat controversial in some quarters, but you have now collected a huge experience. Tell us about how many cases and what kind of follow-up you've got.
In this paper, we actually followed 629 patients from 1996 to 2007, originally from the Baylor College of Medicine and subsequently at Medical University of South Carolina. We followed them over 10 years and assessed their symptoms, their treadmill performance, and the echo indices over this period of time.
So the criticism that this technique looked like it worked acutely, but we got to have more data, we got to see how long it followed up. You feel like you've answered the question. Is this a acceptable method for treating this condition?
Short of a randomized control trial comparing various methods, this is the best information we have about alcohol septal ablation and the long-term results. And we have demonstrated that we have benefits as far as symptoms are concerned, both angina and dyspnea at 3 months, as well as improvement in exercise tolerance, as well as improvement in echo indices of gradients, as well as septal thickness over a period of time.
So everybody knows that, of course, you've got the outflow gradient, and the outflow gradient seems to go away acutely, as you've shown. What happens to the outflow gradient over time?
Over a period of time, we have demonstrated that the outflow gradient continues to go down and remains minimal, both in the provoked as well as in the resting gradient, and that we think is related to left ventricular remodeling and thinning of the septum, both by scar as well as by regression of hypertrophy in these patients.
One of the things that scares people sometimes with this kind of treatment, and it's been raised as arrhythmogenicity, and whether creating a scar in the septum is going to be a setup for arrhythmias down the road. What did you find from your experience?
From our experience, when we looked at the survival curves of these patients over a 10-year period of time, the survival at 1 year was 97%, at 5 years was 92%, and at 8 years was 89%. And considering that these patients were on the average 7 to 9 years older than the myectomy cohort of patients from the Mayo Clinic or Toronto General, actually the survival curves look almost very similar. So that is very reassuring to both the physician as well as the patient who are trying to assess which procedure is right for their patient.
So you're comparing it to surgical myomectomy, and you say that the results look pretty comparable as far as...
They look comparable because we don't have any randomized control trial. The best myectomy data are from the centers which are very good at myectomy, and these results are from centers which are good with alcohol septal ablation. So they're slightly different in that way.
Well, certainly the debate will go on as to what is the best treatment. Both of these seem to accomplish the goal of getting rid of the gradient. And getting rid of the gradient, is that helpful for the long-term outcome? What do you think?
Yeah, we actually think that reduction of the left ventricular outflow tract gradient is beneficial. For one reason, I think that it reduces the incidence of sudden cardiac death. And reducing the gradient either with myectomy or alcohol septal ablation gives them a better chance, helps diastolic dysfunction, as Dr. Naga has shown in his previous studies. And we have a companion paper by Cuoco et al., which actually looks at the incidence of ICD firings in these patients, and actually it is not significantly increased. So the concern about the arrhythmogenic risk caused by the scar is more than offset by the favorable ventricular remodeling which we see in these patients.
So in selecting our patients for this, you've shown if we find a patient with a gradient, should we recommend this, or are you reserving this only for people who can benefit symptomatically? What kind of selection are you utilizing?
I think we used a very stringent selection based on the ACC-AHA consensus criteria, and it's only for symptomatic patients, and it's also for patients who are refractory to medical therapy or who have intolerable side effects from medical therapy. Patients who are class 1 or class 2 and who have minimal symptoms, myectomy or alcohol septal ablation is not the right approach for them. It's only for relief of symptoms and relief of outflow gradients in patients who have symptoms that we have demonstrated the benefit.
So drug therapy is your first choice, and if that doesn't work, you have two clear options, myomectomy or alcohol septal ablation. Both seem to work. Thanks for this great contribution to JACC intervention and to the medical literature, and I look forward to your future investigation in this field. Thank you so much.
Thank you very much.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.